have a hepatocellular cancer, and my surgeon has mentioned radiofrequency ablation, the person who asked the question said there's been a lot of, she's done a lot of research on her own and is going for a second opinion, but I can't seem to figure out if there is a better type of ablation, and so is interested in which option is best. Well, we touched upon that earlier. Ablation just means destruction, and ablation can be destruction with heat, which would be microwave. And I think everybody understands microwave is just a form of thermal or heat therapy. And microwave is one that we've had a lot of interest in recently. Microwave is a very effective modality. You basically will take a probe and direct it into the tumor under either ultrasound guidance or CT guidance, and the microwave energy will then destroy the tumor with heat. Radiofrequency ablation we've been using for a number of years, probably close to 2 decades now. The microwave has some promise in that it seems to be a more efficient source of energy. It's quicker, less anesthesia time. So we're beginning to do more and more microwaves and fewer radiofrequencies, but the jury's still out, I think, as to which one's more effective. I think both are quite reasonable.
Dr. Kuvshinoff, there's an individual in Eau Claire, Wisconsin, asking about their elderly father who's scheduled for an RFA next week, and they want to know what the recovery time is after RFA.
Well, radiofrequency ablation or microwave ablation can be done a number of different ways. It can be done in the radiology department through the skin, where you don't make any incisions, and those patients do quite well. They can go home the same day or at most an overnight stay, and they can be back on their feet within a couple of days. There's a little bit of discomfort associated with the treatment, especially for tumors that are on the outs of the periphery of the liver. For example, the liver sits under the rib cage, under the diaphragm, so if the tumor is on the top of the liver next to the diaphragm, there will be some irritation and discomfort for a few weeks after that. But in general, it's very well tolerated, and a couple of weeks of recovery time. Now, if the radiofrequency or microwave ablation is done in the operating room under a general anesthesia, it can be done laparoscopically through the little mini incisions, and those patients tend to stay overnight, and have maybe a 2 to 4 week recovery. If the surgery has to be done open because of the size of the tumor location or because other things are being done at the time of surgery, then you may be looking at a 6 to 8 week recovery period. For patients who are older and more frail, we'll favor the more less invasive approaches because we don't want to have a long recovery period if they have medical problems or elderly for those reasons.
One other question we have here is from someone in Vineland, New Jersey. I know sorafenib's a targeted therapy, but how does it work? Thank you for that great question. Sorafenib is an oral drug, and it is an antiangiogenic drug. So what that is since hepatocellular cancers are so vascular, they have a lot of blood supply. What this drug is intended to do, or what it does, is it targets the tumor's blood supply. It also targets some signaling within the cancer cells. So to be very specific, it inhibits vascular endothelial growth factor signaling, as well as the RAS-RAF-MEK pathway. These are different pathways by which cancer cells signal each other and progress and grow. And that is how sorafenib works. For further information about sorafenib, I would urge you to contact on the web. There is a program called NextConnect, and this is run by Bayer, the company that makes Nexavar. So if you needed further information, if you're starting treatment sometime soon and just wanted some support, an online number that you can call, some resources, they are very, very good at helping with those kinds of things.
So, Dr. Iyer, Alana sent in a question online. Is cirrhosis reversible to get better liver function and then to have surgery, or I will add any other treatment? So is cirrhosis reversible?
Well, unfortunately, cirrhosis is not reversible. It is basically your body's response to the hepatitis, to the inflammation. and it is really scar tissue. And unfortunately, that is not reversible. What is reversible sometimes, though, is if patients develop, for example, a blood clot that causes a stress on their liver and causes the liver to decompensate. Sometimes they have a portal hypertension, and that leads to a variceal bleed, for example. For a period of time, their cirrhosis may appear worse on certain scales, and once that has been treated, things can look a little bit better. However, as in general, as an answer to your question, cirrhosis is not reversible.
Another question just came in, and the question is, are these treatments, and we're going to say the treatments that we discussed in this talk, are they available everywhere in the United States, or do you have to go somewhere special?
I think the transplants being very specialized, obviously you would have to go and look up your local state transplant centers. And given the limited availability of organs and the expertise required, the entire team required to take care of these patients, these are reasons why it has been determined that in certain geographic regions there should really be one site that specializes, does large numbers, and thereby keeps up their skills. For all of the other procedures we spoke about, chemoembolization, radiofrequency ablation, all of these techniques should be available in most big tertiary cancer centers. Smaller hospitals may offer one or two of them, but given the expertise required and also the infrastructure with some of the equipment, it is unfortunately limited to slightly bigger hospitals. But it should be available throughout the country.
A couple of specifics regarding surgery, for example, liver surgery and some of the more complex surgical interventions. They're best done at centers where there's a lot of experience and there's a lot of data and information that what we call high volume centers or facilities and surgeons who do these procedures frequently will have better outcomes than centers where they're done very infrequently. So that would be a general comment that we would say about any complex surgery. There are also something to be said for doing this in centers where there's a coordinated effort. In other words, where these patients are discussed by all the different specialties. And what we do and what many cancer centers and other centers do throughout the country is we have what we call multidisciplinary conferences where we all get together and meet and we discuss the patients and look at all the different therapies that we discuss to see which the best therapy would be. So it's very helpful if you have a very wide portfolio of different options available. We can really look at them and see which one would be the best option.
One more question someone had from New York. Was that I've had a liver transplant almost 4 years ago for primary cancer of the liver. What is the expected survival for patients like myself?
So for liver transplant, it's a very, very good therapy first and foremost. If in the right patient with a disease that's limited to the liver, that's not advanced, the results with liver transplant are very good. The 5-year survival can be as high as 50 to 70%. And the reason that it tends to be better is that not only does it remove the tumor, but it also removes the rest of the liver that's at risk for forming new tumors. So where we fail oftentimes with liver cancer, the rest of the liver, cirrhosis and inflammation from hepatitis, new tumors can form. Every year there's a chance that new tumors can form. The liver transplant gets rid of that unhealthy liver as well as the tumor, so it can be associated with the best results. But again, there's the limitations that we have because of the availability of the organs. There are patients that go on the liver transplant list that have progression of disease or have to have other things come up where they get delisted and don't get the liver transplant. So not everybody that gets on the transplant list will ultimately get a transplant. Now another question here talked about strategies. The patient asked, patient is eligible for a liver transplant, but the doctors recommended TACE, which Dr. Iyer referred to earlier as the chemoembolization, to do that first while the patient is being evaluated and waiting for liver transplant. The reason that that's done is while the patient is waiting, they don't want the disease to progress. So if they do and prevent it from progressing. The other reason that they use these, what we call bridge treatments or a bridge to transplantation, is that if you can kill part of the tumor, then it may change your score. So if you have a lower score, which means you'll be lower down on the waiting list, you can start to treat the tumor, and if you decrease the size of the tumor, that might increase your chances of getting a liver transplant, because they really want to transplant patients who have the best chance of long-term benefit. So these bridges to transplantation include TACE, radioembolization with the radioactive spheres. Sometimes we'll use radiofrequency ablation. So all of these things can buy time waiting for the transplant and prevent disease progression.
One of the other questions someone had was, why is hepatocellular cancer so much more common in Chinese people or people of Chinese descent in the United States compared to Americans? And that unfortunately has to do with the chronic carrier status of individuals in China. Hepatitis B viral infection, unfortunately, can cause hepatocellular cancer, as you know. And in China, a number of people, up to 8%, they say, of individuals are chronic carriers of hepatitis B, and that puts them at greater risk of developing hepatocellular cancer. In fact, 40% of all HCC diagnosed in the world are patients from China, and that is the reason. Another question someone had was, what is the best way to follow someone that has been treated with liver cancer to make sure that their tumor is only in the liver and is nowhere else? And our preference, and we serve on national panels that make recommendations on how patients should be followed. A good quality CAT scan with IV contrast done in different phases to look for these tumors is ideal. And an MRI scan can also be very useful in some individuals when the CAT scan is giving us some sort of ambiguous result.
We just got a question. Are there a limited amount of chemoembolization procedures that can be administered for a person's liver, or is this procedure unlimited for the person's life?
That's a good question. There isn't an upper limit on the number of times you can have chemoembolization. There is, however, an upper limit on the number of times you can have TheraSpheres or cirrhospheres embolization, and that has to do with the amount of radiation that was delivered in the first treatment or the second treatment. So the upper limit is determined by your liver function and the amount of radiation delivered. But in terms of chemoembolization, unfortunately, even though in theory you can do it many times, in reality what happens is when you block off the blood supply to a tumor, the tumor manages to parasitize, find other smaller blood vessels that will now feed them. And as you go up and down this track, it becomes harder and harder to get back and effectively eradicate this tumor. So in reality, most patients who have progressed after having chemoembolization 3-4 times in a short period of time will not be thought to be best candidates to do it again and again. But I think that is based on the clinician's judgment, their tolerability, and what other options are there for these patients.
It does get technically more difficult, or interventional radiologists that we work with that do these procedures. The more times you do it, it does become a little more technically difficult to do. Although we have had patients with at least a half a dozen chemoembolizations and or more, and we're able to control their disease for a longer period of time.
The median number for all patients with HCC is about 3. So. One other question someone had was, my mother is on Nexavar for liver cancer and is having some trouble with her blood pressure, which the doctor said could be coming from the Nexavar itself. And what questions should I be asking? What other drugs should I be talking to my doctor about? That's another very good question. Since these anti-angiogenic drugs are targeting blood vessels, specifically of the cancer, they do have some unwanted, unnecessary side effects such as blood clots, elevated blood pressure, some cardiac side effects if someone has bad heart disease or has had a recent stroke, blood clots in their legs, and these are all side effects known to happen with anti-angiogenic drugs. Sorafenib is, of course, Nexavar, one of them. 5% of patients in the big clinical trial that led to the approval of sorafenib did have problems with hypertension. And this can be managed like any other hypertension as long as the drug is working and there were not any serious consequences from that high blood pressure, such as a stroke or a heart attack. Your primary care physician or your oncologist should be able to manage it like any other high blood pressure with an ACE inhibitor or depending on what other drugs your mother is on.
We had a question about what statistics about surviving cancer in someone who's almost 80 years old. And we generally don't think of age alone as a criteria for determining whether we should treat someone or not treat something. We really look at their, if they're frail, are they very active? I generally ask them what do they do on a typical day, what is the most strenuous thing they do they get out a lot? And those things are very helpful to me to see how aggressive we might get with treatment. But in general, I mean, we do have to consider age, especially when we're talking about major surgeries or transplant surgery. So in general, the more frail a patient is, the more we're going to consider less invasive treatment. So for example, rather than a liver resection, we may consider a radiofrequency ablation or microwave ablation, or alternatively an alcohol ablation, which can be done without detriment to quality of life. So we really do look at the quality of life question in addition to the survival benefits, because we want to make sure that whatever treatments we do aren't going to have any serious side effects. And when we're dealing with cirrhosis, there's always a sort of a tug of war between very aggressive therapy on the liver and making the liver function or the cirrhosis worse, because we don't want to treat a tumor too aggressively and then have a patient go into liver failure because they have a very marginal liver function. One of the things that Dr. Iyer always has to consider when she's giving her treatments is the effect of her treatments on the liver function. And there are some limitations in patients who have abnormal liver function. So Dr. Iyer, are there any limitations in terms of how healthy someone's liver is to giving them these treatments, whether it's systemic therapy or chemoembolization?
Absolutely. So with chemoembolization, because this is going to also affect the healthy liver a little bit, cut off the blood supply and a small piece of healthy liver, many centers have their own individual criteria, but for example, here at our institute, bilirubin, which is one of the liver function tests, more than 2, the presence of ascites or fluid within the belly, blockage of the blood vessels, the main blood vessel, the portal vein, all of these would be contraindications, and then this person would not be a candidate for chemoembolization. And they would be referred to consider some sort of systemic therapy where they're not in jeopardy of losing their liver function as a result of the treatment itself. And sorafenib or Nexavar, our center focuses primarily on hepatocellular cancer here, is approved for treatment of patients with Child-Pugh class A, so really the healthiest livers. And that is because, unfortunately, the same liver has to metabolize this drug and excrete it. And if the liver function is limited, poor, unfortunately, the drug will not get eliminated, it will circulate for a very long time, and all of the known side effects would be in greater proportion, more severity, more frequent, and that is why we have to hold it back. Some patients with Child-Pugh class B are also candidates for treatment with Nexavar, but Child-Pugh class C, the most vulnerable, if you will, in terms of their liver reserve, patients are not good candidates for any systemic therapy.
What type of scan is best to figure out if the cancer is only in the liver? We touched upon this earlier, but I'll just say a couple of things. Typically, the two scans that are most common that we get to diagnose liver tumors are CT scans, and they do have some radiation, but they're very good scans for not only looking at the liver, but looking for at the lungs, the lymph nodes. MRI scans or magnetic resonance imaging scans don't have radiation in the sense that CAT scans do, and they are very good for looking at the liver, and MRI scans are also very good for distinguishing benign from malignant tumors. So we use MRI scans very much when we're trying to figure out what an abnormality in the liver is. Is it concerning for cancer? Is it not concerning for cancer? When we want to look for the stage of the cancer to see if it's spread anywhere, then we want to go back to CAT scan. So we use the two scans, we use them both, and we use them both pretty extensively, but we typically are asking different questions with the two types of scans. So when there's uncertainty as to whether a liver tumor is something we should be worried about, MRI scan will be very good. When we're trying to stage and just see what the total extent of the tumor is and whether or not it's spread outside the liver, we'll use CT scan, especially when we're talking about metastatic tumors to the liver. Earlier in the talk, we talked about primary liver tumors, meaning the tumor starts in the liver, but even more common than primary liver tumors are we see tumors in the liver that have spread from another organ. And when we're looking for where that tumor might have come from, CT scan is invaluable for doing
that. One other question someone had here was, where can I find other people who are suffering from late-stage liver cancer to connect with and get support from? That is another very good question. Definitely, all of the support you can get, nutritional advice, psychosocial support is very important for you and your family. The American Cancer Society, I would urge you, based on where you live, I don't know what the big centers there are, but that would be the place to start. And they do have support groups, general support groups for patients with late-stage cancers. And they also will have, if they don't have one locally, they can connect you online to support groups for liver cancer. If you are looking for resources, you're welcome to come and look at the roswellpark.org website, where we can provide some of that support as well.
Here's another question, and what are some of the side effects of sandostatin, and how many years can a person be on the medication? Now, we did get a couple of questions about carcinoid tumors, which are different than primary liver tumors, but some of the treatments overlap so much that we'll just take a moment here to talk a little bit about carcinoids, because we've got a couple of questions. So a carcinoid tumor is a type of what we call neuroendocrine tumor that it can occur anywhere in the GI tract or in the lung, and it very, very frequently spreads to the liver. So on the liver team, we are very often taking care of patients with these hormonally active carcinoid tumors. And sandostatin is one of the most common drugs to treat that. So I'm going to ask Dr. Iyer, just if you could briefly tell us what sandostatin is and what the side effects of sandostatin might be.
So sandostatin, also called as octreotide, which is the generic name, is a drug that is a synthetic analog of our natural body's drug called somatostatin. And what this drug does is it targets some receptors present in these neuroendocrine cells and prevents them from secreting certain hormones. In addition, it can inhibit insulin-like growth factors, some other growth factors that allow the cancer to grow, and thereby it can slow cancers from progressing. So specifically, its approved indication for use in the United States is for the treatment of carcinoid syndrome, flushing, diarrhea, wheezing, all of the symptoms that occur from hypersecretion of hormones from this cancer. However, recently some studies have shown that giving this drug as a long-acting injection once a month can also slow the progression of carcinoid tumors, and it is being used for that indication as well.
And what about the side effects of sandostatin?
It's generally a very well tolerated drug. Some patients will develop malabsorption, diarrhea. Occasionally, patients develop palpitations, high or low blood sugars, and gallstones. For the most part, these symptoms can be managed symptomatically, but if any of these problems occur, certainly you would contact your physician that's prescribing the drug.
Well, with carcinoid tumors that spread to the liver, almost all of the therapies that we talked about, even transplantation, liver resection, ablation, all of the therapies we discussed, except for some of the targeted therapies and the chemotherapies, are all applicable to patients with carcinoid. So there's a lot of overlap, and I'm sure that's where some of these questions came from. There's other tumors that are also candidates for some of these therapies. For example, certain patients with colon cancer or colon and rectum cancer that has spreads to the liver in a limited way, we can remove part of the liver or do radiofrequency or microwave ablation and have patients cured even in the face of spread to the liver. So nowadays with aggressive liver-directed therapy, candidates for that who undergo surgery can have as high as a 50% 5-year survival. So half of the patients we are alive at 5 years, even in the face of disease that's spread from the colon to the liver. So we've made a lot of progress in that area, as well as with the carcinoids. Now, with these aggressive, between surgery and the radioembolization with the SIR-spheres, together with chemoembolization and sandostatin, we're able to keep patients who have liver metastases alive, whereas about 50% of them, only 50% were alive at 5 years. We're now keeping 70% to 80% alive, and even up to 10 years. A lot of our patients with carcinoid tumors that spread to the liver are alive 10 years after their diagnosis with liver cancer. So we're really making some progress in that disease. I guess the other question, I guess, from Dr. Iyer would be, is every patient that is diagnosed with liver cancer, are there certain patients in certain stages that really we don't have any treatments for, or are there any other alternative treatments or comfort types of treatments that might be applicable to some patients that have more advanced disease?
Certainly. The goal of treatment in the setting of advanced disease, which has metastasized to multiple organs and their liver function is limited, those are for patients with a poor performance, overall poor health. Those would be patients that are not very good candidates for any of the treatments we just listed. But in those patients, hospice care is very helpful for patients who are having a lot of cancer-related fatigue, low energy, poor appetite, and their supportive care measures can really make a big difference in quality of life. One other thing that we didn't talk about is treatment of pain using radiation for bone metastases. Liver cancers can spread to the bones and have a lot of pain from that. And again, pain medications, nerve blocks, radiation therapies can be very helpful in that setting. These would be the majority of patients. Occasionally, we'll have patients that develop ascites or peritoneal spread of their cancer, or just liver failure-related fluid buildup in their belly. And palliating or supporting those patients, because it is quite uncomfortable to have this fluid in their belly, by doing repeated drainage of this fluid, or even putting a small catheter in their belly to intermittently drain this fluid out and relieve their discomfort, are all options available to patients with more advanced stage disease.
Our hour is coming to a close. In summary, patients that have primary liver tumors should be evaluated by experts in the area of treating liver and malignancies. A experienced surgeon should evaluate the patient to see if there's any option for surgical resection or ablation. It's important to have the option of transplantation discussed. If patients are not surgically operable, there are a lot of less invasive options such as radiofrequency ablation, microwave ablation, and newer modalities such as the nanoknife, and other procedures that can be done in the radiology department. We talked about chemoembolization, We talked about radioembolization using very microscopic radioactive beads that can be delivered to the tumor through a catheterization. We talked about systemic therapies, both oral and intravenous therapies. And we also, at the end, talked about what we call supportive care or palliative care. We discussed the issues of liver function. It's very important that we consider what the patient's liver function is. And we also need to consider the issues such as quality of life and also the expected benefits of these various procedures. So it's a complex subject. There's lots of different ways patients present. There's lots of different therapies and treatments. And we generally approach this in a multidisciplinary fashion, discuss the patients with the entire team of cancer specialists to provide the best care. Because the best care is generally when the initial diagnosis and treatment plan are carried out in the best interest of the patients. So I'm Dr. Boris Kuvshinoff, co-director of the Liver and Pancreas Tumor Center.
And I'm Renuka Iyer, co-director also of the Liver and Pancreas Tumor Center. And in conclusion, I would like to thank all of the viewers and participants of this program for making it a success, and end on a positive note that there is hope for these patients. In the last few years, several new technologies, new studies have been done, drugs have been approved, and there remains work to be done. But with your help and participation in these clinical trials, there are several new drugs on the horizon. And so I encourage you to look into local trial options, local major centers where all of these different newer technologies are available to you, and explore whether you are a candidate for this therapy, because we are in fact in the era of individualized treatments for each individual patient. Thank you very much.
Good night.